next presenter, Dr. Amy Meadows. Thank you so much, Dr. Meadows, for being with us. Dr. Meadows is Division Director of the Child and Adolescent Psychiatry Division and is in our UK Department of Psychiatry. And she currently runs the Pediatric Psychiatry Consultation Liaison Program at Kentucky Children's Hospital as well, and is an Associate Program Director for the Triple Board Program at the University of Kentucky. So she specializes in evaluating and treating children and adolescents with complex concerns. So she is very well positioned to give us an overview of the evidence around children. Thank you so much, Dr. Meadows, for being with us.
Absolutely. So I'm delighted. So like Dr. Oros, I'm also trained in pediatrics in addition to psychiatry. I think that there is a lot of important kind of crosstalk and relationships that the fields can have. And certainly taking care of someone's physical health includes mental health. So I think that it's really important that all of you are learning. So if someone could advance my slides, please, that would be great. So I'm just going to go over kind of the practice gap, which is that in primary care, even though there's not a lot of training in mental health, primary care providers still end up taking care of depressive disorders and other psychiatric conditions. Next slide. And so my hope today, this is a very brief presentation and it's kind of a 30,000 foot overview, but my hope would be that we're able to kind of give a little bit of guidance and provide some of the information and the evidence about the pharmacologic treatment of adolescent depression. Next slide. So I just wanted to Dr. Oros's information very much applies to adolescents. A lot of the same features that she talked about also apply to adolescents, but that sometimes depression can look a little bit different in adolescents compared with adults. And so I wanted to highlight that sometimes instead of saying, I'm depressed, teenagers can say I'm bored, which is a very common way that they express depression and anhedonia. And it may be that they're more irritable or that they have somatic complaints like headaches or stomach aches, saying, I can't go to school. They may have social withdrawal. Previously, they'd been very, active, engaged, and are now isolating to their room. It may take them longer to do things, or they may refuse to do things that were previously easy for them, like homework. So just sometimes it takes a little bit higher of a threshold to kind of have a suspicion for adolescent depression, and sometimes you have to ask specific questions. And so it's really important just to have that on your radar. So next slide. And I wanted to talk just a little bit specifically again about adolescents and youth suicide. So suicide is the second leading cause of death in kids 10 and up. And that has been that way for almost a decade now, when it surpassed homicide as the second leading cause of death. The most recent statistics are that about 1 in 5 adolescents at some point during their high school or middle school years will have thoughts of suicide, and even daily thoughts of suicide. So pretty intense thoughts of suicide. And about 1 in 5 adolescents are diagnosed with some kind of mental illness. So either depression, which is one of the most common, anxiety, bipolar disorder, some mental illness that does increase the risk of suicide. And at any given time, about 25% of adolescents would meet criteria for depression. And that's actually an increase in recent years. And if you could advance the slides. One of the really important factors for adolescent mental health has been COVID-19. And I think as many people recognize, COVID-19 has resulted in just a flood of adolescent mental health concerns and crises. ER volumes for adolescent mental health complaints have skyrocketed, really. And there's some evidence that things like eating disorders and really serious mental illnesses have increased in adolescents during COVID-19. And I think, these highlight that 37% of adolescents report that they experienced some sort of poor mental health during the COVID-19 pandemic. And 44% reported feeling kind of persistent sadness or hopelessness during the past 12 months, which, again, we looked at the prior slide, which was kind of cumulative data that 25% point prevalence of depression. And so this is nearly double. And I just want to mention that the CDC also came out with a recent study looking at adverse childhood experiences during the pandemic, which showed a dramatic increase in 2 or more adverse childhood experiences experienced during the pandemic. And so I think it really highlights that, not only are kids struggling, but really families are struggling as well. And many of those kind of dysfunctional household stressors are really affecting youth mental health, in addition to other factors like dysfunctional internet use and some other problematic concerns. But next slide. And then this is the thing that I really want to highlight. Most depression across the country in youth is untreated, completely untreated. So about 60% of youth who would meet criteria for depression or who do meet criteria for depression are untreated. So this, I think, is a call for everyone to be screening, be mindful, and really be addressing pediatric mental health as early and as possible, because unfortunately, statistically, there are many ways that kids struggle to get into the mental health system. So if we can ease that for families and kids to start treatment in a primary care office, we're making it more likely that they're going to have a good outcome. So next slide. So I just wanted to go over kind of pharmacologic strategies. And again, they're very, very similar to adults. Next slide. Really, medication is a very, well accepted, well evidence supported first line treatment for depression, as well as some psychotherapies. And like Dr. Oros also mentioned, addressing kind of comorbidities. Sleep is a huge one in adolescents, and especially with devices that kids are up sometimes all night with their iPhone notifications. They're sleeping with it right next to their head, or they've got 2 devices going on. They're watching TV in their room. They've got lights on all night. Their sleep pattern can be really dysfunctional. So understanding that there are some really important comorbidities and addressing those early can be important and can be things that are easily done in a primary care office. So I'm going to talk a little bit more about medication. So next slide. So really, the best evidence that we have is that both medication plus therapy gives us the best chance of recovery. And so in an ideal world, if we had kids who, had immediate access to all resources, we'd get them involved as quickly as possible in both, medication treatment and therapy. And I still think that it's worth talking with families, making referrals, but as we know, sometimes that doesn't happen. And what I really want to point out is that medication treatment alone is still really good. So about 71% of kids after 12 weeks will have significant improvement in their symptoms if they're doing both medications and therapy, and about 61% will respond if they have just medications, which is really pretty good numbers. So next slide. So emphasizing that medications are first line. Medications are excellent treatments. And so I know sometimes there's reluctance to start even SSRIs in a primary care office, but they're very good, and they help kids feel better. Next slide. And then I want to kind of, again, highlight medications are first line. So that same study that we just looked at, the treatment of adolescent depression, the TAD study that was published in JAMA, they did a long-term follow-up and looked at kids who were in the various conditions and how they did long-term in their global functioning. And so you'll see that the first 3, the medications alone, the therapy alone, and the combination treatment alone, and the combination of both therapy and medications all did relatively well 4 years out from the initial study. But the kids who received placebo for those first 12 weeks actually did worse long-term. And so, the takeaway that I have from the study, next slide, is that treatment delay can lead to worse long-term outcomes. So yes, it's completely, reasonable to talk with families about getting kids into therapy, getting them into mental health specialists. But my emphasis here is that even a 12-week delay in getting effective treatment leads to significantly worse long-term outcomes. So while somebody's in a referral queue for psychiatry or for therapy in local areas, talking about starting mental health treatment, even if it's medications in the office, is really, really important. So next slide. So again, the most evidence that we have in kids is for fluoxetine or Prozac for adolescent depression. You can start very low, so they make a liquid form of Prozac for very young children, but most of the time for adolescents, I start around 10 milligrams, and I do dose increases about every 2 weeks and kind of assess how kids are tolerating it. I'll just mention that escitalopram is also FDA approved for adolescent depression, but we do use other SSRIs, even if they're not FDA approved, just because there are so few things that are FDA approved in kids. And really the evidence that we have is that first-line treatment for medications for adolescent depression are SSRIs, second-line treatment for adolescent depression are SSRIs, and then it's the SNRIs or other medications. So really trying the SSRIs first and second if possible. Most common side effect is GI upset, which is typically time limited for the first couple of weeks. And there is a risk of agitation or kind of what we think of as secondary mania. And so it's just something to counsel families on, especially if there is a family history of bipolar disorder, that some kids may actually become activated and may kind of have their energy levels significantly increase. I will say that there is a black box warning. I'm going to talk about that a little bit. And so the FDA does recommend weekly face-to-face evaluations for the first month of treatment. I'll say in practice, this is really very challenging. So typically what we recommend is to have some sort of weekly check-in, and whether that's that we have the family call, have the family do a nurse visit, make sure that we're kind of monitoring for safety, especially if there's any pre-existing suicidal ideation. We want to get them in as quickly as we can, but just practically speaking, sometimes doing weekly evaluations during the first month of treatment can be challenging. If you have a therapist already working with the kid, that can also be another good check-in or an option for kind of doing those evaluations and making sure that they're tolerating SSRIs. Next slide. And so I just want to emphasize that there have been several meta-analyses, again, that have really proven that that SSRIs are effective, they're safe, and they're the best treatment. So this is a meta-analysis from 2016. Fluoxetine is effective for adolescent depression. Next slide. And another meta-analysis in 2017. SSRIs and SNRIs work in kids. So the bottom line is to get comfortable with a couple of SSRIs. Fluoxetine is a great one, and use that to help kind of treat early so that kids are getting their depression addressed. Next slide. And just to briefly mention, so the FDA does have a black box warning regarding increased suicidality, potential increased suicidality in kids and young adults. And so this is something that we talk with families about. We mentioned that there is the possibility of increased suicidal thoughts. However, the studies show that it's about a 2% increase in suicidal thoughts. And generally, we don't think that it's associated with suicidal actions, but it's really important to monitor and to talk with kids about how they're doing and how they're feeling. And overall, the number needed to treat for adolescent depression or anxiety is between 3 and 10, which is well within the range of what other medications that we use. Like antibiotics are generally in the 3-4 range. So these are very close to the number needed to treat for other effective medications that we use. And the number needed to harm with just one incident of suicidal thoughts is about 1 in 143. So our risk benefit strongly favors treatment. Next slide. And again, so just like Dr. Oros mentioned, thinking about when to refer adolescent depression. So, I think that the things that we would recommend kind of doing an immediate referral to psychiatry is if depression also has psychotic features, if there are complicating comorbidities, especially coexisting substance abuse, which can really complicate treatment. And again, active suicidal thoughts, intent, plan. If there's any concerns for safety, that is an instance to refer to your local ER or to engage 988, which is the National Suicide Hotline. Next. And I just wanted to mention that we at UK are working on some initiatives to help extend access to child mental health. So we're working with the local AAP and HRSA to have what's known as an access program for Kentucky primary care doctors and pediatricians. It's going to be called Kentucky Kind. And really the goal is to help train pediatric primary care providers. So there will be webinars, there will be information available, but also help to get consultation with mental health providers and child psychiatrists. So next slide, that's all I have. I am happy to answer some questions. I already see one in the chat. The question is from Dr. Jasinski. Sleep is a very common complaint in adolescents. Additional interventions. So yes, to all of the interventions that you mentioned, environmental modifications, CBTI, medication. So typically, non-medication interventions for sleep are first line. And I try to get as much mileage as possible out of the very simple kind of sleep hygiene sorts of interventions, which actually surprisingly to me, seem like they are novel information when I present them to a lot of families, talking about putting phones outside of the room, talking about having a bedtime, using the bed only for sleep, not for sitting and doing homework, not for eating. I think with, COVID, lots of people's schedules got kind of off kilter. And, I think some of the things that we would consider healthy sleep habits got thrown off. And so doing some very basic kind of education around sleep is usually my first approach. And CBTI is great. And there are actually some apps that can help. And I think for adolescents, especially, app-based mental health can be something that is really, really helpful. So there are some free CBTI apps. The VA has one, and then there are some paid ones like Sleep Rate, which does CBTI that's kind of self-paced. So those are all options kind of when we run into roadblocks. But honestly, they are more effective than medications to do the kind of hygiene CBTI interventions. And some, obviously, we'll talk about medications, melatonin, but honestly, I use melatonin often as a vehicle to get people to do buy-in to sleep hygiene. Like, melatonin works best if you lay down in a dark room and it's quiet and you take it at the same time every night. So I'm kind of adding in some sleep hygiene with the melatonin.
Dr. Meadows, we had a quick question. What is CBTI?
CBTI is cognitive behavioral therapy for insomnia. So it's an adaptation of cognitive behavioral therapy that specifically targets sleep.
Focus on sleep. Yep. Great. Thank you so much. And those, we'll try and get some links from you, Dr. Meadows, if you don't mind, to those sites that you referred, and provide them to folks after today's Zoom call. So thanks so much for bringing that up. Those resources